This is useful especially in a type 3 pattern of the septum of the fibers where you don't have you don't have the covering so of the His bundle, so you can have a better capture. So septal pacing is sometimes enough. Always conduction system pacing exactly is not required. So these are when you stop. When do you stop? As you screw on, sometimes you get the template beats. So you stop at where you get the template beats. Template beats or fixation beats otherwise called. These have a RBB pattern in V1. They are narrow QRS ectopics. So when you see these ectopics, stop the screwing and pacing from the lead at that point will produce the same morphology QRS as you have seen the spontaneous beats. So this is where you can know that you have hit the conduction system, you have irritated the conduction system, and you tend to place the lead at that point of time, at that point of position. And in a stylet driven leads, you can continuously monitor the passage through the septum. As you pass, you connect the stylet to the electrode and you can know the EGM throughout. So when you see these ectopic, you can stop at that point of time. In a non-stylet driven lead, this is not possible. You have to stop at when you find the spontaneous ectopic, try to pace at that time. So how do you know when you have perforated into the LV? So that's not perforation is not a life-threatening thing. It is very innocuous. You just need to take it back or screw it back, unscrew back by anti-clockwise rotation. So but you can't leave there. The problems are, one, you may lose the pacing. Suppose it's a dependent pacing with complete R block, patient may have a syncope, or you may have a stroke due to the tip in the LV cavity. You can have a stroke. So that's the two worries if you leave the lead perforated. So how do you know perforation is? This is a paper by Dr. Hanma Sundaram. He had best is to see a unipolar EGM. Once you see a unipolar, if there is a complete perforation, first is that it will not pace. Second is that you can see a negative QRS. Even without pacing, you will see a negative QS pattern with a slurring in the downstroke. That is indicative of complete perforation. Suppose you see a biphasic complex, it indicates a partial perforation. And you can see a transition that shows the selectivity of the conduction system. So if you have a selective capture, that is two thresholds, as you go down on voltage, initially the broad QRS will become narrower and it will further become narrower. That is called as a selective pacing. And this is a LV septal and a non-selective pacing ECG morphology. Here it looks it's all RBB morphology, but it narrows down as you go to, so it's a selective pacing slightly wider, but, and you note the R wave peak time in V6. So you try to get less than 75. Less than 75 milliseconds is very specific for actual conduction system capture. But if you get somewhere between 80 to 100, that is still a very good V6 R wave to peak time for bundle pacing. So generally the endpoints for bundle area pacing is narrow QRS. If you get a fixation beats, then shorter R wave peak time, less than 75 is 100% specific for that you have captured the left bundle. And selective pacing on reduction of pacing voltage. Suppose you get that pattern, narrowing of QRS and change of myocardial to non-selective to selective capture, that pattern is specific to nearness to conduction system. And flat baseline to pace QRS very specific for a capture to conduction system. And impedance loss is not always faithful, it depends on your lab. Suppose you get a reduction in impedance of around 200 to 300, that is the time when you stop screwing. Otherwise, you might have perforated. At that time, you can take it as a time to check the unipolar whether you are perforated or not. The HOT and LOT-CRT, that is addition of a coronary sinus lead in addition to a conduction system lead. You can stop with just pacing the conduction system and make it a pacemaker and add a pacemaker rather than a CRT to reduce the cost. That is possible in many cases, but sometimes an additional coronary sinus lead is advantageous. These are especially when patients have a additional IVCD, distal conduction disease. Such patients, additionally, it's better to have a HOT or a LOT-CRT, additional epicardial pacing lead in addition to the conduction system pacing. This, otherwise, it may not completely correct the left bundle, bundle branch block over time. Initially, when you implant, it might be okay, but after 5 years, that may not be the situation. So always in such cases, a progressive conduction system disease, whenever we suspect, suppose you are doing a CRT for a sarcoid, then probably it is better to always to put a HOT or a LOT-CRT rather than, if it's an MI, it's okay. MI fully revascularized, it might be okay. For a DCM with a possible progressive scarring, or even sarcoid, disease like sarcoid, ARVD, all these cases, it's always better to have an additional coronary sinus lead. Conduction system lead is just an addenda. And generally, response rates improve with a HOT or LOT-CRT. The studies, of course, shows that HOT-CRT actually reduces QRS duration by 24% compared to routine conventional CRT, and LOT-CRT is less by 11%. But the thing is, whether you do a LOT or HOT, the reduction in the quality improvement and EF improvement is much better, and it's not different between HOT and LOT. Even though QRS is slightly, just because there's an RB pattern in LOT. So even though HOT produces a very low, his bundle pacing produces a very low QRS, there's no difference, much difference between the two. And clinical trials always shows that there is the LOT-CRT is not very inferior compared to perfect his bundle pacing. So the studies are all ongoing. There are disadvantages and advantages of both left bundle pacing and his bundle pacing, but still data yet has to come. And some unanswered questions are, is left bundle pacing as good as his bundle pacing? That's still not yet answered. What is the most optimal criteria of left conduction system capture is not yet, it's not final. There are many criteria being there. Validation is still going on, but nothing is conclusive. Is there a difference in clinical outcome between proximal distal bundle area pacing? Is left bundle capture necessary to achieve maximal benefit in patients bradycardia patients or patients requiring CRT? Studies yet to come. What is clinical impact of delayed activation? Such things are yet to come. But whatever said and done, it has been showing promising results. How much is it so different and beneficial above a routine CRT? Yet we have to know. We know that patients, there is acute short-term improvement. Like short-term, nowadays we can take up very nicely patients with even RV dysfunction, where earlier we don't take for CRT with patients RV dysfunction. You note that post-procedure you may have collapse. We have seen many patients with CRT. Now that doesn't happen with this conduction system pacing added. That is one sure. Short-term results are very good, 6 months, 3 months result, but long-term we don't know. Only studies will say.